Hi, this is Brian Kim. I'm going to share with you case number 279 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. So this is a dense traumatic cataract. You're going to see the zonular dehiscence, and I'm going to use trypan blue, which I always do in these typical cases with trauma, and then place a capsule retractors, specifically to be able to help stabilize the zonules, and then placing a capsular tension ring, and utilizing techniques to minimize any torsional stress on the zonules because of my mechanical fracturing techniques. So this is the narrow blade speculum, but this patient has a little bit of a heavy brow, so I'm switching it to the asymmetric speculum. This is the right eye, and you can see by having the broader blade retracting the lower lid, it limits how much retraction and pulling down there is, and it does provide some preferential retraction to the upper lid, which is helpful with a heavy brow. You can see this patient has a strong Bell's reflex. I'm trying to use a cotton tip to steady the eye, asking the patient to look straight ahead and not to squeeze or move. And this is the corneal marker, which will help me to center and size the rhexis. I'm just touching the eye and noticing the patient's quite reactive. I'm trying to reassure the patient that I'm just touching the eye, that there's nothing sharp around the eye, and he settles down. And then I make my incision on the right side. You can see how much this patient's moving his eye. And then I'm controlling the eye, asking to look down, using the cotton tip to fixate the eye, and then I make the superior incision on the left side. This is some intracameral epinephrine, and then some dispersive viscoelastic. And this is the 2.4 millimeter main incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And I use that cannula to control the eye as I do that step. For some reason, I said, maybe I should put some trypan blue in, because otherwise I would have put the trypan blue in first. But I had a sneaky suspicion that maybe putting trypan blue is a good idea. So after you have viscoelastic in the eye, it's not a big deal. You do have to put the trypan blue under the viscoelastic, right on top of the anterior capsule surface. As you push the trypan blue, you just have to use a cannula and kind of sweep side to side and push. You can use a cannula kind of like a paint roller to paint the anterior capsule surface. So as I try to evacuate the stained viscoelastic, the stained with dye, I'm gently pushing the viscoelastic out with some more viscoelastic. And this is the microrhexis forceps to do my capsule rhexis now. I'm puncturing the center, using the can to control the eye with my left hand. As I puncture, you can see how easily I'm able to puncture with a sharp tip microrhexis forceps. As I pull, notice something. The lens is very wobbly, very wobbly. You can see the stria. You see the stria as I'm pulling. And it takes more effort to pull and create the rhexis. Why? Because it lacks the counterforce. And what is applying the counterforce is zonules. When your zonules are crappy, as you pull, you can see all the stria within the anterior capsule. You saw that stria. And so there's no reason to damage more zonules. I'm just going to make some more incisions, which will help stabilize the capsular fornix in the capsular bag so I can finish the rhexis. So these are the MST capsule retractors, and I like these because they're bendy. You can place them through a standard paracentesis incision. And I place this one now, and then I'm going to continue my rhexis. And because the capsule retractor engages not only the rhexis edge, but also deep into the capsular fornix, you have really good stability and control. I place a second capsule retractor now that I've made a little bit more of the rhexis, about another quadrant of rhexis. I place a capsule retractor, again, goes through very easily through a paracentesis incision, again, retracting it and engaging the stopper, cinching it down some more on both sides, and then using the microrhexis forceps again to complete the rest of the rhexis. So you can tell based on the rhexis that the zonulopathy is mainly nasal. So nasal zonulopathy, I have capsule retractors to help stabilize not only the anterior capsule, but also capsule fornix. So when it comes to phacoemulsification, I don't have to worry about the fornicel capsule coming up towards the phacotip and getting eaten by the phacotip. This is why it's so important to use capsule retractors, and iris hooks are really a bad idea in this situation because there's no fornicel support. If you start emulsifying the lens piece, that fornicel capsule will just come right up if the zonules are not pulling it back like they should be. So I perform some hydrodissection using the capsule fornix hydrodissection technique, but I don't spin the lens on purpose because of the situation. And then I'm going to go in with irrigation off, turn on irrigation, remove the surface epinuclear material. I'm going to slide the chopper under the rhexis edge, but then I said, okay, why don't I just go ahead and do a little sculpting? So I switched to sculpt, and I start sculpting a trough. No reason to get myself in trouble. Go ahead and do some sculpting. Again, not as dense as I thought it was going to be, so I did a little sculpting, and then I'm sliding the chopper under the rhexis edge contra-incisionally, performing a terminal chop maneuver. If you can't tell, there's a little bit of zonular weakness. The lens bag diaphragm is pushed back quite a bit here. I'm pushing some more dispersive viscoelastic. I take the phacotip out. And what happened was the capsule retractor slipped. And so I pushed some more viscoelastic, stabilized the anterior chamber, came out with a phacotip, and now I'm trying to do a better job in engaging the capsule and the fornicel area with the capsule retractor. And that's the nice thing about this. You can just adjust it. At first, in the very beginning, the capsule retractor was on top of the lens material. But now that I'm starting to remove some of that lens material, it ended up being loose. The capsule retractor was loose. And so in order to deal with that, I just stopped and then we cinched it down. Performing another cross-chop maneuver, getting underneath the lens material peripherally, pulling it centrally toward the phacotip to try to crush and remove that lens piece. Using a little bit of vacuum to pull up some of the lens pieces. Again, I'm being very ginger. I don't want to turn this lens, right? Because this is a case of zonulopathy. But you can see the Veritas is really good. I was able to just grab the lens piece and just pull the entire lens up out of the bag, at least that one portion of it. And as I'm able to loosen it up, I start to chop it using my phacotip and the chopper to crush the lens segment that's coming up above the iris plane. And then again, using my instruments to crush the lens pieces and then emulsify the lens pieces. And because I use vacuum to pull that piece up, now you can see the lens is very loose. And very carefully using some vacuum to grab the pieces on the tip and then using the chopper to crush the lens against the phacotip. And the corneal endothelium is nice and coated with the dispersive viscoelastic. When you're dealing with these zonulopathy situations, you have to always be mindful. It's so easy for the zonules and the capsular bag to just create trouble. And so you have to be very mindful. Look for any areas of zonulopathy. Look for any breaks in the posterior capsule. But so far, I'm doing well. So I take the chopper out and the phaco tip out and switch to the eye and a handpiece. And very carefully, starting subincisionally, I'm just very gently teasing off the cortical material off the bag, subincisionally first, and then going around circumferentially. I'm trying to tease the cortical material, grabbing the anterior component, and then just kind of teasing side to side. More tangential forces, not forces towards the center. That will cause more focal stress on the zonules. By turning and teasing side to side in a more tangential manner, you're applying more diffuse forces on the zonules and not focal forces on your zonules. And therefore, in my opinion, this is really a gentler way to peel the cortex in the context of zonulopathy. So right here, it's all about foot pedal control. And you can see I'm able to very gently come right up to that cortical material. Of course, some of it is incarcerated by the capsule retractor. And at some point, we'll be taking that capsule retractors out. But the capsule retractors did a nice job in stabilizing the capsular bag nasally. I know that the zonules are not very good nasally, but I was able to get the lens out. I did not worry about the posterior capsule flying up towards me, and that's because the capsule retractor provides fornicel support. The tip of that retractor is very, very deep into the capsule fornix. So here I'm using the BSS cannula to just pulse BSS into the capsule fornix, and it looked pretty clean to me. And then I'm turning off an infusion and then pushing cohesive viscoelastic to fill the bag, and then I come out with the eye and a handpiece. So again, you have to disengage the fluid before you push the viscoelastic in. And so this is a capsule tension ring. I like to lift it up out of the platform and then place it through the injector, pushing some more cohesive viscoelastic to fill the bag. And this is the Lester hook. I'm opening up the main incision, sliding the injector, the CTR injector in, and I'm going to use a Lester to hook the leading eyelet. As I deliver the CTR into the bag, the leading eyelet is engaged with the Lester. This basically contracts the diameter of the CTR, and by doing it that way, it minimizes any tractional forces on the zonules, and then I'm able to place the CTR into the bag. So this is super easy as far as disengaging the capsule retractor. You pull the stopper back, disengage it, turn it sideways, pull it up, rotate it 90 degrees, and it slides right out. Super, super easy technique. Again, same thing. Disengage the stopper, slide the stopper back, disengage the capsule retractor from the bag, turn it 90 degrees sideways, pop it out of the paracentesis incision by rotating it. Super easy. This is the single piece acrylic lens placed into the capsular bag. Again, using the cannula, the viscoelastic cannula, to position the lens and making sure the haptics are completely disengaged from the optic. And then I'm going to remove all the viscoelastic from the anterior chamber in the bag. And in this case, I do not go underneath the lens. I'm trying to be very careful. Don't want to disturb the bag at all. Just very carefully removing all the viscoelastic. But I see that the lens is sitting a little funny, so I push some more cohesive viscoelastic to fill the bag. And I'm trying to make sure I rotate this lens a little bit, because there is some weakness nasally. So I'm going to rotate the lens so that the haptics are oriented vertically. So now that I've rotated the lens, go ahead and remove all the viscoelastic from underneath the lens. You saw how much it jiggled, and that's, again, as that cohesive viscoelastic came out, it just jiggled wildly. But you can see otherwise, this is a very stable situation. If this lens descends and dislocates in the future, at least I can use a CTR and lasso the CTR with some suture scleral fixated to the eye if it comes to that. So again, pretty tough case. You have to make sure you use mechanical fracturing techniques, minimize any rotational stress on the zonules in the capsular bag, utilize the capsule tension ring, and be able to place a capsule tension ring even though the capsular rhexis is not complete, and you can use it as counterforce when you have a challenging capsular rhexis due to poor zonules. And you saw I placed 2 capsular retractors as I made my rhexis. Again, very careful technique of disassembling the lens. And because the Veritas has great purchasing power, I was able to grab the lens, pull it up out of the bag, chop it up into smaller pieces, placing a CTR using the Lester to compress the leading eyelet, which compresses the diameter of the CTR, which minimizes zonular stress. And that was the end of the case. So I hope this was helpful to you, and I thank you for your attention.